Ooh, is it just warming up again? I don't know why. Oh, should be all good. Okie doke. So a lot of you have probably heard the phrase before, comparing apples and oranges, and please help yourself to any of the apples and oranges that you'd like to take. And some of us really have this impression that science is science, and everything that we know has a measurability, and that it's very different than the types of things I'm going to be talking to you about, and that we really can't compare something like complementary alternative or integrative medicine with something like biomedical research, that they're completely at odds, they're completely different, completely separate. It's like comparing apples and oranges. But I'm going to actually suggest to you that maybe they're not that different, that the things that you think that you know, and you've already run into several controversies in this course already, that maybe the things that we think we know are actually not as firm, not as concrete as we'd like to think. And this gets back into this whole issue. When we talk about things related to complementary alternative medicine, and some of you will know individuals, because if the statistics that I mentioned to you in the last class are actually correct, you'll have people in your family who take multivitamins, or you'll have people in your family who might be taking other supplements that they've heard are really good. Educated individuals, individuals who have good jobs, and etc. Why do they take those? And is there anything in terms of the science behind the types of things that they say actually benefit them? And I want you to be thinking about this. Are they really that different? Is our trust and our faith in biomedical research better than what we say is not really valid research that goes on in complementary alternative medicine? So I'm a biologist, and I take the position that we should be looking at it from an evidence-based perspective. And I'm hoping that at the end of this, that you'll also be looking at it from an evidence-based perspective. So one of the interesting things that I happened to see in the news the other day, actually came out on the news feeds yesterday. If you're taking herbal remedies, where you've heard that something natural, and again, this is one of the themes in terms of integrative medicine, that natural is better, that your own body uses natural sources in a better way, that the material that's actually found in these herbal remedies, actually there isn't. So you might be taking something that says that it has St. John's wort, and when you actually do an analysis, there is no St. John's wort. But people still think that it helps them. They still believe that it's beneficial to them. They actually might feel better. And there is a biology associated with that. And that's something that we're going to be talking about today. Some of the different pathways that we use ourselves, and maybe perhaps complementary alternative medicine isn't that far-fetched, that there is a way for us to make ourselves feel better from a biological perspective, not sort of magic, but from a biological perspective. So I talked to you about Steve Jobs, and the fact that a really, really smart individual like him had pancreatic cancer, decided that ultimately, even though his doctor, his best advice from the best doctor on the West Coast, a cancer specialist, a surgeon, actually suggested that he get this tumor operated on that he ignored that advice, and he decided that he'd let his own body heal him. And of course, his pancreatic cancer spread. He had to have a liver transplant. The cancer continued to spread, and of course he died a few years later, back in 2011. And he thought that just drinking carrot juice by itself, carrot juice only, would be able to cure him of cancer. And again, think about this. He's not an ignorant individual, one of the smartest business minds of our time, one of the most innovative people, getting the best medical advice, and he decides completely to ignore it. And we talked about reasons why. People use this. There are lots of people who use it. People in your own family are going to be using complementary alternative forms of medicine. Some of my colleagues in the office, all with PhDs, decide that complementary alternative forms of medicine, where there's no active ingredient involved at all, might actually be better for them than taking traditional medicine. If they have a headache, maybe take something else instead, etc. And we know also that there are different forms of complementary alternative medicine, and I'll be using this abbreviation CAM here, that maybe this might actually work. It might actually be beneficial for them. And over half the people that use CAM have this idea that maybe in addition to conventional medicine, that taking this might actually be of benefit. Some people just thought, well, I'll give it a shot. It might be interesting to try something different, to try something that isn't traditional. There's a lot of thought, just like Steve Jobs, that, you know what, all that stuff that you're telling me, actually it's not going to help me anyways. So why don't I just ignore your advice, even though you're telling me that having this surgery, I might be extending my life by 20, 25 years. I don't trust you. I don't believe that that's actually true. And in some instances nowadays, especially in North America, more and more individuals are actually being or having CAM recommended to them by their healthcare professionals. So there are lots of reasons for this. And of course, the last reason, not so much here in Canada, where we have a fairly good, not great, but fairly good drug plan, universal healthcare, etc., that the costs are really too high. And again, these are American statistics. So again, who's more likely to use CAM? Women are more likely to use CAM than men are, although men also use CAM. Surprisingly, or maybe not surprisingly, it's actually the more educated individuals, people who have gone to university, who have university degrees, and people who have money that actually use CAM more than those who don't. These are also middle-aged individuals. They're not older individuals. They're not young people like yourselves, but it tends to be middle-aged individuals. There are other ethnic groups that seem to use this more frequently. For example, individuals who have African or Caribbean descent, those who are from Asian descent are more likely to use it than individuals who have identified as being Caucasian. People who are suffering from chronic illnesses where there is no known cure, things like cancer or AIDS or myalgic encephalopathy, where we have no cure for these things, and having myalgia, where you have muscle pain, is actually very, very painful. As we mentioned with pancreatic cancer, if you have a pancreatic form of cancer, it's so painful that you actually get a surgery to actually block that pain pathway. And pain is a big indicator for things like CAM. So you might think, okay, you know, there are lots of people that use it. I understand that. There are lots of reasons why people use it, especially people who don't have any other known cures that are available to them. But why are scientists so concerned with CAM? Like, why bother? Sure, you might have people who, like Steve Jobs, have all of these different assets that are available to him, and he passes away for reasons that actually don't need to be expanded on, because he could have gotten better. But why do scientists have a lot of skepticism with CAM? Some of this is really because there is very little evidence to actually back up claims of effectiveness. Now, think a little bit about this. When you hear someone say, you know, I tried this and it worked really well for me, that is not really evidence. That's what we call in science an anecdote. It's anecdotal evidence. There is no rigorous scientific study. And here at the University of Toronto, one of the things that you learn in every single class that you have is, You know, we learn about these pathways because these experiments were done. These experiments were then confirmed in other labs, etc. And this is sort of the scientific process that I mentioned to you with Rene Descartes, Isaac Newton, and others. In many cases, the evidence seems to be very, very circumstantial or anecdotal. It worked well for me. You try it, and it doesn't work at all for you, period. Past attempts, when they start looking at these different forms of CAM, have really had mixed results. They don't seem to be consistent. And so it's not really clear if the actual drug or the therapy is all that efficacious. And in fact, the vast majority of the skepticism with CAM really resides on this, that there's very little research that's done, not in the ways that we do it. So they don't do randomized control trials, and I'll talk in more detail about randomized control trials in the next slide. It often depends, according to CAM practitioners. You know, it didn't work in you because you actually were really skeptical. Well, imagine if you were given a Tylenol, and that Tylenol didn't work on you because you didn't think it would work. Most drug manufacturers would not even put that on the label, but for CAM, that's a big deal. And when they try to do scientific, evidence-based types of research, a lot of it is really due to the fact that they claim that there is the outcomes that they are expecting are often very dependent on some of those social factors and cultural factors that I mentioned to you earlier on, as well as in some cases spiritual beliefs. Now we're going to talk a little bit more about this down the road, and I'll come back full circle as to maybe why this may or may not be a good thing. But when we talk about evidence-based practices, when we want to overcome this skepticism, someone has said that this herbal remedy that you're taking and it works really well on you, doesn't work at all on me, how do we make sure that overall, in terms of a population, how do we get to an evidence-based practice that actually says that, you know what, there is something to this drug that people have been saying for many years is actually efficacious if you are suffering from depression, for example, or some other anxiety disorder. If you take this drug, it actually works. How do we actually make sure that a clinical study is good? One of the foundational beliefs that we have as scientists and as people who practice evidence-based research is that a good trial, one that would involve things like complementary alternative medicine, needs to have randomization. You can't just be putting people that you know are going to say that the drug works. It has to be randomized. It has to be double-blinded. They don't know what they're getting. Neither do the people who are administering the drugs. And it also has to have a placebo. And this is what is a good randomized controlled trial. This is the way that we determine, does that chemotherapeutic agent, does it actually work better than a placebo rather than saline, etc.? And so these randomized control trials often rely on these placebos. Have you all heard of placebos before? You're all comfortable with the notion of placebos? Yes? So I'm going to ask you to hold on to that thought. In the best studies that we have right now in North America and Europe, when we are looking at the efficacy of a drug or a treatment, we have to use a randomized controlled trial that when we're talking about a drug or an active agent being delivered, needs to have a placebo associated with it. That is how we compare whether drug A is any better than just a placebo, where there's no active ingredient. Keep that in mind as I go through the rest of today's lecture. Again, randomization, no pre-selection, placebo, there is an inert substance that's given to some of the participants, and it's double-blinded. And that's the way that we run our tests. That's the way that we would like CAM practitioners, if they are actually saying that this drug works, that this herbal remedy works, that's the way that we would like them to set up their evidence-based clinical trials. But the other thing to make or keep in mind is that when we look at the scientific literature, one of the things that we need as scientists is to be able to confirm a hypothesis, confirm a finding, to confirm an experiment that's been done. And we know, for example, that even in biomedical research with things like GDF11, irisin, and other factors that are reported in the best journals, that there's a lot of controversy associated with them. But we also know that when we talk about complementary and alternative forms of medicine, we now see more and more of the evidence-based types of studies that I've just outlined. More and more of those practitioners for CAM are publishing in places that get cited on PubMed. So when you look up things on PubMed, related to a herbal remedy, a different type of therapy, etc., you will now find more and more articles that are found on PubMed. And for individuals who are citing that, you know, this gives us legitimacy, it actually tends to lead some credence to what they're saying, that it's in a peer-reviewed journal. So many of these articles that are found on PubMed, for example, are things like different herbs, whether or not they're actually in the pills that you buy over the counter or not. In these published journals, there definitely is an active compound or an extract, or there might be a biology based form of alternative medicine, something that's given to you that impacts your biology. And I'll give you an example of that in a few moments. But it's often done in a very, very restricted setting. It is not done sort of in a randomized way. People are pre-selected, and this is one of the major caveats. So when scientists take a look at this, they say, you know, that's not the way that we do it in terms of science. We can't say we're going to take all the individuals that have this sort of belief system and put them in this group and know that they're in this group and give them this drug, etc. So there are lots of controversies and lots of struggles that are associated with this. However, we know that nowadays that this sort of growing field is being impacted directly on science. So one of the best journals that we have in our discipline as life sciences, students and researchers, is Science magazine. And in August 2010, the editors of Science decided that they would do a whole article devoted to complementary and alternative forms of medicine and integrative medicine. And what they said was surprising. Back in 2010, what they suggested was, you know, there might be something to all the things that are being reported on PubMed. But there's still a lot to be done before we can say that this actually is good for someone with Alzheimer's to take as a form of remedy, etc. So are scientists taking note of all this? Absolutely. Is it something that is mainstream? Not yet. But there are some hurdles that are being more and more overcome by practitioners that want to have this evidence-based form of research in the literature. So when you're evaluating the different claims, and some of you might be really interested in this, your parents might ask you, you know, I heard that if I take echinacea, that my cold will be cured a little bit faster, or if I take ginkgo biloba pills, that I'll be feeling a lot better. You have to evaluate all of these claims based on what evidence is really there. And sometimes the evidence is somewhat good, sometimes the evidence is not so good. So when you're looking at accuracy, were the reports that you're seeing at the back of the bottle that you're taking a look at, were the reports taken out of context? When you hear about a citation, are there actually authorities in the field? Because there are. So when we talk about placebos, everyone knows about Bernadetti, for example, and I'll show you some papers by Bernadetti. Are experts in the field actually being cited in these types of studies that involve that form of biology? Is there any bias? Is there, for example, nowadays, at the very first lecture I gave you, I told you right from the outset that I have no financial compensation, etc. Imagine that you're getting money from a drug company actively promoting this particular drug or this particular type of therapy that might involve complementary alternative forms of medicine. A lot of these studies are old. And it's the same thing in science. When you see an article in Science that was published back in 1996, and there's been no subsequent follow-up work at all, then the currency of the literature and the currency of the research comes into question. If it's that big and if it's that important, why has no one else followed up on that research? If that was such a big therapeutic impact in cancer and this chemotherapeutic drug works on cancer, why has no one done anything since 1996, etc.? The other thing, even in science, this is one thing that we take very, very seriously. And this is something that, for example, we've talked about in biomedical research. When we look at things like iRisin and when we look at things like GDF, 11, if it's only one lab that consistently comes up with the same sorts of results, this coverage is really not there. If that same lab all the time is coming up with it and no one else can do those types of experiments, then that becomes an issue for us as biologists. And it should be exactly the same sort of issue that comes up when you are looking at complementary and alternative forms of medicine. The other thing that makes this really complex is when we're looking at this as researchers, we look at a whole range of different types of studies. We look at observational studies. So what do we see in individuals? Anecdotal evidence, in other words. But we don't just rely on observational studies. We rely on clinical trials and studies. If we see this drug working on more and more individuals, that more and more people say that, you know, every time I take this compound X that's derived from this plant, that I actually feel good. And if enough people say that, then we will put that into clinical trials. But not all forms of complementary alternative medicine get to clinical trials that we would put any faith into. So again, all of these different things, is it controlled, double-blinded, is it randomized? And even better, in terms of randomized controlled trials or RCTs, not just one group of individuals, not only a randomized control trial that's being done in Toronto, but it's done in Toronto, Boston, in Beijing, and wherever else. If it's multi-center, that's always better than just having a single center randomized control trial. So all of these different factors go into examining the research. And most times, complementary and alternative medicine really gets stuck at observational level studies, that these individuals that took it, that were pre-selected to take part in this trial, showed great benefit versus those that didn't take it. And these types of observational anecdotal studies, if they don't move into clinical trials, and if we don't get a mechanism from it, a lot of people are skeptical of that. And we'll sort of just leave that for the time being. Any type of trial, whether it's publicly funded through the National Institutes of Health, or it's privately funded, because of the FDA regulations that are associated with it in the United States, whether it's complementary forms of medicine, whether it's stem cell research, whether it's a new chemotherapeutic drug, all have to be posted and listed and updated as to the overall success or failure on this particular site, clinicaltrials.gov. And you'll see that overall there are very few sort of complementary and alternative forms of medicine that are undergoing clinical trials that are open to the public to be able to be accessed. And if they're serious and if they're evidence-based, they should be on that website. So I'm going to go through one scenario, and I would like you, as I mentioned in the last slide, to really concentrate on the biology of this. I know some of you have heard of multiple sclerosis before, and maybe some of you have heard a little bit about it but weren't that familiar with MS, and we'll talk a little bit about why we are looking at this in terms of alternative forms of medicine. So multiple sclerosis is a disease of the central nervous system, and it affects all sorts of things in your central nervous system. Most of you will think that it affects movement, and it certainly does, but it also affects lots of other things. So it will make you feel more tired, and it's a central mechanism that's working through your brain. It might have cognitive impairments. You won't be thinking as well when you're going through multiple sclerosis. It might lead to things like depression. There are issues with your visual system. You might have nystagmus, where your eyes kind of move really rapidly from side to side instead of being able to fix your gaze. You might have neuritis or an inflammation of the optic nerve. And there are things that affect your speech, like dysarthria, etc. And many of these things go back to the fact that something in multiple sclerosis affects your central nervous system. And what happens is that there is a gradual demyelination of the neurons in your central nervous system that result in all of these different types of things. There's demyelination in the visual pathways, there's demyelination in the musculoskeletal pathways, in the sensation pathways, even in the autonomic nervous system and control of bowel movement. We don't really know what causes MS. Even as biologists and even as researchers, we are not 100% sure of what causes multiple sclerosis. We know that there are different forms, and we think we understand some of the biology, but we still don't understand everything. We know that it is not typically a genetic disorder. It's not something that is inherited, and we don't know what the cause is, if it's a deficiency, for example, in a major histocompatibility complex or in the HLA antigens. We're not 100% sure. We think that there might be something that relates to being genetically susceptible, and also you need an environmental impact on top of that. But we're not 100% sure of what causes this, because it doesn't seem to be inherited. Someone in your family, a close family member, might have multiple sclerosis, and no one else in the family will be affected. The diagnosis itself is still rather difficult. So imagine one day your leg starts to feel a little wonky, or you start to feel really, really tired. It could be due to a number of things, and this diagnosis itself is rather difficult. So what often happens is, if you start to think you have something related to a neurological disorder, and you think that you're feeling tired, or you're not able to see as well, or you tend to be a little bit more clumsy than you have been in the past for whatever reasons, oftentimes you'll be going in to see your GP. Your GP will probably not know what's going on, and then they'll refer you to a neurologist. And the neurologist, as well as taking a patient history, like how are you doing before, is there any kind of inflammation that you've had recently, etc., will then do a series of MRIs. As a neurologist, they'll take a look at your CNS. They'll also use evoked potentials. They may also do a lumbar puncture to see if you've had an infection in your CNS. And then with the evoked potentials, they'll be able to tell, are your nerves firing normally? By sticking in electrodes on the nerves to see if the normal nerve conduction velocity is occurring, these evoked potentials will let them know, is there something wrong with the nerves that is leading to all of these different types of things. So multiple sclerosis has a number of other biological features associated with it. So the symptoms and diagnosis occur in the worst period of time that you can have in your life. Because when you are between the ages of 15 and 40, those are the ages where you're actually supposed to be thriving, where you're supposed to be doing the best, where you're supposed to be building your family, building your career, finishing university, going off to get married, starting your job, buying your home. These are the age ranges. But this is where multiple sclerosis tends to impact you at this really inappropriate time. It is 3 times higher in women than it is in men. There are higher incidences in countries that are north of the equator. So Canada actually has one of the highest MS rates in the entire world. And in Canada, there is one province that has the highest rates out of every province. Do you know which province that is? Ontario is not that province, but do you have an idea like which province might actually have the highest incidence of MS? And they have like the best research related to MS as a result of that? I don't know if you count Saskatchewan as a province, but I do. If you count Saskatchewan, then Saskatchewan actually has the highest incidence of multiple sclerosis. So how bad is this? So 3 Canadians are diagnosed with MS every single day. So you might think that's not so bad. You know, we have like several million Canadians, 3 Canadians diagnosed with MS. And again, it's in the age range where they're supposed to be the most productive. Again, the incidence rates of individuals that affected vary by country, but we have one of the highest rates, and it tends to vary by province, etc. And it can be individuals from 1 out of every 500 individuals up to 1 in every 1,000 individuals here in Canada, depending on the province. That's high. If you think about a lecture hall and you're sitting in that lecture hall in Con Hall, which holds 1,000 people, 2 of those people sitting in there are likely having MS. Even within our program in your course, there are individuals that have MS, and I can tell you that they have MS. I won't go into specific details, but we're affected here directly in HMB204. The majority of individuals that have MS have a form which is known as the relapsing remitting form of MS. And you've heard of individuals that have MS. They get better for a while, and then they'll have to go back to using a cane because they have multiple sclerosis. And more than 80% have this form of MS. But this is actually not such a great thing, because half of those individuals will also proceed further. That relapsing remitting, where you get better for a little while and then you go back to having MS symptoms. Your vision might be blurry, you might be more fatigued. These will actually develop into the really bad form, which is called secondary progressive multiple sclerosis, and that is where all the troubles begin. So we don't really know what is happening within MS. We think that it might be something to do with autoimmunity. We don't think that it's genetic in origin. And we think what's happening is that there are immune cells that are attacking the myelin sheaths, which normally are not immunogenic to them. And as a result, you get this demyelination of certain groups of neurons, which means that you can't have action potentials progressing down them as you normally would. And this is where those evoked potentials come into place. Oftentimes what happens is on an MRI, as you see down here, you see these white inclusions. So there's one here, there's another one here, and another here, and another suspicious looking white patch here. And these patches and plaques actually are where we think that there are demyelination events going on, where something might be going on in the white matter. And these can disappear over time, and these can come back. And these relapsing remitting forms that you see here are often one indicator of the progression of the disease itself. Over time, though, this becomes somewhat irreversible, and the myelin can't actually recover. This might disappear, or it might decide that it can't repair itself anymore, and that inability to transmit action potentials then becomes permanent. And that's when you get into that progressive form of multiple sclerosis. There is no cure currently for multiple sclerosis. You manage the symptoms the best that you can. There are three current current drug strategies that are in place for this, but it's really just a management system. We think that it might involve the immune system, it might involve inflammation, and so there are three broad classes of drugs, each of which are these bullet points here. So there are immunomodulatory drugs that are used to manage sort of these bouts of immune attack. As well as inflammation. And again, you don't have to worry about the names that you see over here like Avonex, etc. The most important thing that you can see is that most of these involve interferon 1 beta. All of these are different types of drugs. All of these are modulating the interferon beta 1b or the 1a. The other thing that is often used are steroids, and particularly corticosteroids, as the second line of defense to reduce the time of relapse. So when you are having a really bad episode of multiple sclerosis, your leg really hurts, or your leg muscles feel weak, or you can't see well, that's a really bad outcome for you, and you want to recover from that as quickly as you can, then you'll often be given some corticosteroids to try to reduce the time that you have these different symptoms. And then the last one are other drugs that are used to treat symptoms like pain or other issues with your muscles, etc. So think a little bit about what I just mentioned to you in terms of multiple sclerosis. The biology itself, we don't know a lot about. We know some things. We know myelin is definitely affected. We know that interferon 1 beta goes up. We know that overall we can identify demyelination events, and we think that's what causes multiple sclerosis. There is no cure. It's not something that gets better. We know that individuals that have it go through a really, really rough time, including having issues with pain in some individuals as well. I told you that one of the reasons why people use CAM is because there's no cure. So things like AIDS, for example, things like different forms of cancer where there is no hope left for them. So imagine you are in the end stages of multiple sclerosis. You have the progressive form of multiple sclerosis where slowly your muscles are going to be wasting away, you're going to stop breathing at some point. Would you be willing to try anything? Maybe you would, not sure. And so this gets into a sort of different aspect, not sort of taking a herbal remedy, but maybe basing this on what we think we understand about the biology of the brain, etc. So this is Dr. Zamboni. Some of you might have heard of Dr. Zamboni. He was in the news an awful lot a few years back. So he's a surgeon and professor at the University of Ferrara in Italy. He had a wife, he still does. He has a wife, Elena Ravalli, who was 37, 38 years old. So she fits into that age range that I mentioned to you, 15 to 40. So he's a professor of neurosurgery at the university, and his wife started to develop the classic symptoms of multiple sclerosis. So imagine that you're in a position where you can actually research, do things, and impact a disease that hasn't really had any relevance or meaning to you, and now your wife has this. So one of the things he started to do was he looked into the literature. He wanted to know, how can I help my wife as a neuroscientist, as a neurosurgeon? How can I help my wife who has this horrific disease that I really didn't care about until now? So he starts to look at the overall literature, and he finds a link that is very, very old, hasn't been replicated in a very long period of time. So again, we talked about currency of literature, and he links iron as well as multiple sclerosis. Increased iron load in the brain causes multiple sclerosis. It activates the immune response, etc. And it suggested that the higher the iron load was in the brain, that it left more iron deposition. And what he decided to do was to see, is there that link between iron deposition in the brain, blood vessels being affected, as well as potentially losing glial cells that cause multiple sclerosis. So his initial report actually suggested that in 90% of the multiple sclerosis patients that he looked at, that when he did ultrasound on the blood vessels of the brain, especially the ones that were on the venous side that drained the brain, that they tended to be smaller, which meant that less blood was flowing out of the brain. So any blood that was flowing into the brain that had high levels of iron, in the 90% that he looked at, would be staying there longer and longer. So he's thought, as a neurosurgeon, if this is true, and I can actually impact the blood vessels, maybe I can expand the blood vessels, make them bigger, make blood flow out of the brain better, reduce the amount of iron in the brain, and maybe help individuals with multiple sclerosis. So he came up with this new technique, which he called the liberation therapy, to open up these blood vessels. It's also called CCSVI. And as a result, in 73% of the patients that he looked at using this chronic cerebrospinal venous insufficiency surgical technique, they got better. After he opened up the blood vessels that drained the brain, they got better. The symptoms of multiple sclerosis disappeared. But the issue was this, and everyone in the scientific community took great issues with this, in the sense that it wasn't a randomized control trial. There were no controls. It was, you have multiple sclerosis, you want to get better, we'll put you into this study. There was no control. It was not double-blinded. None of those things that I talked to you about in terms of scientific research were really done. And this becomes really this gray zone. So he was the first individual. As a neurosurgeon, as you're developing this new technique, of course, you're going to be the only person who's going to be able to do that for a while. So over time, and this was, again, a few years back, there were other articles that came out to support that, you know what, this CCSVI, this liberation therapy of opening up the veins, actually works. So we should actually look at this as a new form of therapy for individuals. The problem, again, is that all of those studies also did not have controls, were not double-blinded, they weren't properly assessed, etc. And again, a few years back in Canada, we still don't allow this. It's still not funded. If you want this therapy, if you have multiple sclerosis, the only place that you can get this done is in Saskatchewan. In Ontario, if you're suffering from this, you can't get this procedure done. And a Toronto area resident by the name of Mahir Mostic a few years back actually decided, as an individual who had multiple sclerosis, to fly down to the Dominican, where they did this procedure, and he passed away because of complications to this. This led to a big outcry. It also led to the fact that we need to understand what's going on here. And when more and more research institutes started to do these techniques that were now being published, and they had the proper controls, etc. The big study that came out 2 years ago from the University of Buffalo said that if you look at it from a randomized controlled study, and you look at it in that basis, where you're not pre-selecting individuals and they don't know if the procedure's been done or they've just had their the surgery, kind of a sham surgery being done to them, there was no benefit. So in fact, we're back to this gray area. We don't know. Does it really work? We're not 100% sure, but one study from the University of Buffalo that was properly controlled suggests that actually it's an ineffective technique. It sounds really great though. So let me also take you back to another form of biology. So in Genoa, 21 patients were actually put into this study that involves stem cells. So you think, wow, stem cells, you know what? It's got to be the way to go because stem cells offer so much support. We like stem cells in biology. Stem cells can repair anything in biology. Do you guys buy into stem cells being a really effective form of regenerative medicine? It's the future of medicine. So I think that generally speaking, we look at stem cells as being the future of medicine. Let me tell you one thing though. Stem cells work up to a point, and if, for example, you had a heart attack, if I had a heart attack, I would actually want stem cells to be put into the area of the heart that was damaged. But the reality is, when we take a look, stem cells, we don't know how they work. It's not because they're going in and repairing the tissue like you think, oh, I damaged the muscle, it's going to go back and repair the muscle. That doesn't happen. We know that's true. And we know that it actually works to help them, but we don't understand the mechanisms. Are they factors that are being secreted? We actually don't find them in the muscles that we want to be repaired. So it's still a bit of a mystery as to how these stem cells work. But the University of Genoa actually decided to use a stem cell study to see if the immune system could be suppressed. Again, an overactive immune system causing multiple sclerosis, etc. They wanted to know in a phase 2 trial, a clinical trial that was being done, if you were given another drug, mitoxantrone, which suppresses the immune system, which one is better? So again, sort of a controlled study that was being done involving a really hot area like stem cells. So 12 patients received mitoxantrone, 9 patients had the stem cells. They wanted to know which one is better for MS. So mitoxantrone is the standard technique. We take bone marrow stem cells, we give it to these individuals. Which overall immune suppression system, mitoxantrone, a drug that's been used, or the stem cells from bone marrow, which one would be more effective at reducing the immune response in these individuals? So their endpoint, a known endpoint, not just like, are you feeling better, asking an anecdotal question. They wanted to have all of these series of endpoints in advance. They wanted to know if we looked at these individuals after being either given the drug, mitoxantrone, which controls the immune response, or we give them stem cells, which we think will impact their immune response. If we look at them using an MRI, and we look to see, do they develop any new lesions after getting this drug treatment? And can we see if there's a change in the number of these lesions that we can then look at using a contrast medium on an MRI known as gadolinium. So you give them gadolinium, you look at their brains, are they developing more lesions? Are they staying the same? If you're given stem cells or you're given the mitoxantrone, it showed that either way that you look at it, no matter how you looked at it, that these bone marrow stem cells compared to mitoxantrone that normally suppresses the immune system actually works better. Now that was a small study. It has to be replicated. Do you like that study better than, for example, the liberation technique? Well, I would argue that you probably do, because you hear things like stem cells, that you hear that this is a randomized control study, but it's not a true randomized control study. So we'll talk more about designs of experiments a little bit later on, but I do want you to know a little bit about the biology of this. Okay, I'm going to actually not switch gears. This is actually related to the topic that we've just been looking at. How many of you have heard of someone who is a tree hugger? What does that mean, a tree hugger? They're a tree hugger. Means nothing to you? What's the connotation of being a tree hugger? Is that a good thing, bad thing? No, nothing? Yeah. They're about the environment, etc. But here's really what tree hugging is all about. I'm gonna ask you to think back. You know, right now in the 21st century, it's so easy to look at technology and look at stem cells and look at RNAi, CRISPR, and all these amazing molecular tools that are coming out. But I want you to think back to what big news you've heard about biology. maybe it's CRISPR, maybe it's RNAi, maybe it's stem cells, etc. In the 18th century in France, France was sort of the capital, just like the United States is like the big sort of scientific research hub that it is now. France was the big research hub back in the 18th century. And in the 18th century, there's an individual by the name of Antoine Mesmer who's coming out and saying, you know what, I have discovered a brand new type of force. And this force, this animal magnetism, actually allows me to control how individuals feel. And I can make individuals feel like really, really good or feel really, really sad. I can invoke a state of hysteria in them. And this animal magnetism that I've discovered is a brand new force of nature. And he showed this to everyone. He actually was invited to the court of King Louis XIV. He showed this in front of King Louis XIV and his court, that he could actually make women cry. He could make women faint. He could pretty much control their emotional state almost at will. King Louis is like fascinated by this. He's never seen anyone being able to demonstrate this sort of animal magnetism before in his life. So one of the things that he did is the same thing that we do now. When you want to investigate something, you appoint some sort of study or some sort of commission. So he appoints a royal commission. And again, he being King Louis XIV and having all of these resources available at his command, he actually gets together like the all-star group of scientists, right? So he gets together, it's kind of like getting LeBron James and Kobe Bryant in his prime, Michael Jordan in his prime, getting them all together on the same team, and they're going to investigate whether or not this is true. And he puts together this team that includes the best French scientists at the time, Antoine Lavoisier, who has just discovered oxygen, the molecular mechanisms in oxygen, etc., and Benjamin Franklin, the best scientist in the United States. He gets together this all-star team. They go out and investigate this animal magnetism that Antoine Mesmer has mesmerized all of the court of King Louis XIV with. And their basic premise is this. They wanted to know, can anyone actually demonstrate this animal form of magnetism? And what they did was the very first controlled trial that was ever reported. They wanted to know because Antoine Mesmer actually went one step further, and I hadn't mentioned this, but he said that, you know what, if I want to imbue or put my animal magnetism into this stand, I can do that. I can put my animal magnetism here, and if you come and touch this, then you're going to start crying and fainting, etc. And he'd shown this at King Louis XIV's court. So they did the first trial, the first double-blinded trial, the first controlled trial in reported history. So what they did was they asked Antoine Mesmer to come with him. Come with them to the forest. And what he said, what they told him to do was, we want you as the animal magnetism expert to go ahead, touch all these different trees, and we want you to imbue them with the full force of your mind and the full force of your animal magnetism. We want to be able to demonstrate this again. They want to repeat the experiment. Antoine Mesmer goes, sure, I can do that, no problem, right? So he goes and does all of these experiments. And one of the things that Benjamin Franklin and Antoine Lavoisier do is they invite the same group of women who have just demonstrated all of this in King Louis XIV's court to the same forest. And they say, you know what, we want to do the same thing. So your colleague has actually touched all of these trees. We want to see if the animal magnetism still exists within these trees. So they send them off into the woods to go and hug these trees. And when they hug these trees, oh, they start swooning and crying and having hysteria. And at the end of all of this, though, what do you think was the end message? So they had just seen these women hugging these trees and breaking down, crying, and having emotional animal magnetism-induced sorts of hysteria. And what they told them after was, in fact, those trees that you've just been hugging are not the ones that were imbued with animal magnetism. They're the ones that are on the other side. And so what they said was, at the end of this, that the effects were real. The effects were not something that they were play acting on, but the effects were actually due to imagination. I know as scientists, we don't like imagination, right? That whole SpongeBob imagination thing. But the reality is imagination, your belief system, the things that we make fun of in terms of complementary alternative medicine impact us in biology every single day. And in 1955, this was the first use of what is known as a placebo now. And during the Korean War, when drugs that were used in pain management started to drop, surgeons started to give people placebos, just sugar, nothing else, no active substances, telling them that this was indeed morphine or opium, etc., to help manage their pain. Those individuals who had pain, their legs were shot, they were bleeding, they were in great deal of pain, actually they felt better too. This was an effect of the imagination. And these original papers that were then published in 1955 at the conclusion of the Korean War actually demonstrated the use of placebos, an inactive substance that actually has an active sort of role in an experimental setting where it was double-blinded, etc., by Henry Beecher in the New England Journal of Medicine. So it was a real effect that he was observing in the modern setting on the impact of pain. And so we have to look at this as biologists. This is a real effect. Placebo is a real effect. We cannot, therefore, discount a belief system directly impacting someone's response to a drug. So I'm going to leave that here for the time being, and I have to apologize. I think I have quite a few more slides to get through. I'll finish this on Monday, but I want you to think about this over the weekend a little bit, that maybe these placebo effects, that if you haven't thought about the biological basis of this, and if you've been looking at sort of complementary alternative medicine only from the standpoint of traditional medicine, that perhaps we should not be doing that. Okay, so I will see you, I'll see some of you if you're still picking up your midterms at 1 o'clock, and I think that we're still comparing apples and oranges. There still are apples and oranges left, so please help yourselves and have a great weekend. I'll see you all on Monday.